Here's a fact that should shock you. More than 200,000 patients die each year in the United States due to medical mistakes. Medical error is the third leading cause of death in this country. There's heart disease, cancer, and then medical error. More people die from mistakes than from COVID, or from diabetes, from strokes, or from car accidents, or from doing stupid things at the top of a stepladder with a chainsaw. All told, the number of people who die from mistakes adds up to the equivalent of a jumbo jet crashing and killing everyone on board every single day. There are multiple factors at play, but the underlying issue is that doctors are not listening and are not able to listen to their patients. Research shows that on average, doctors interrupt patients within 11 seconds of them starting to speak. Think about that. 11 seconds is the amount of time it takes to tie a shoelace, or peel a banana, to sing the first verse of Happy Birthday. It takes you longer to wash your hands and brush your teeth properly. You cannot boil an egg, or toast a slice of bread, or make a cup of instant coffee in 11 seconds, and yet that is the amount of time patients are given to tell their doctor their story. That means critical information is missed, and misdiagnosis is much more likely. That is the problem. Healthcare is facing an epidemic of medical error. We need to stop allowing distraction and disconnection to undermine the doctor-patient relationship and start making genuine human connection an urgent priority. By placing something as ordinary and affordable as listening and building relationships at the center of our approach to healthcare, we could dramatically reduce the number of medical errors and the deaths that result from them. It's no mystery how this happened. In today's high pressure, high efficiency, high cost healthcare environment, doctors are largely measured by how many patients they can churn through. I say this to you as a doctor myself, an ear, nose, and throat surgeon. Overloaded with administrative tasks and glued to a computer screen, we barely have time to make eye contact, let alone give patients the time and space required to give us their whole story. Sometimes it can seem that we, as doctors, are being measured by our ability to avoid getting to know our patients. And this isn't just a matter of poor bedside manner. Though the precise number varies, it's widely known that approximately 80% of diagnoses can be made based solely on patient history. When we interrupt patients, when we rush through hearing what they have to say, when we tell ourselves we just don't have the time, we're not just being rude. We are actively impeding our ability to make an accurate diagnosis. And this isn't about doctors not caring. We care a lot. That's why we got into this profession in the first place. It's about failing to recognize the power of human connection and resources being stretched in that environment, one in which we don't bother to connect because we're trying to do more with less. Medical error can seem like an occupational risk, a roll of the dice that both doctor and patient have to take. But can we do anything about it? Sure, we'd love to spend more time with our patients. Some of us would, I would, and patients want more time with their doctor. But who has the time? That begs the question, how much time are we talking about? There's actually an answer to that question, and it's less time than you think. About 20 years ago, there was a fascinating study that looked at this very question to see how long patients would speak if doctors didn't interrupt them. Doctors were asked to secretly time their patients using a stopwatch. They were told to start the timer when the patient began speaking and stop it when they finished or when they said something like, "Doc, what do you think?" Patients didn't know they were being timed, and doctors were given a brief training on how to be good listeners, taught how to wait, or nod and make encouraging sounds like, ah, to show they were paying attention. But we're specifically instructed not to ask questions at the beginning of the appointment. To keep appointments on time, they're allowed to interrupt after 5 minutes. What they found was that most people, 78%, will speak for less than 2 minutes. And yet, in the majority of clinical encounters, patients are not afforded the time that it takes to say that sentence. This is not just something we should change. This is something we can change. The solution lies in a fundamental reprioritization of connection as a clinical imperative. The first, most basic, totally doable action we can take is to implement the 2-minute rule. Clinicians can set an intention to give every patient just 2 minutes of their undivided attention and presence at the beginning of each visit. And by doing so, we both dramatically improve our ability to gather data and information and increase patient trust and satisfaction. We also need to elevate listening and communication skills in medical schools, placing them on par with medical and technical knowledge, making them as crucial as anatomy or pathology or physiology or pharmacology as everything else. Third, and this is crucial, the system needs to change. We all have a role to play, both inside the profession and outside of it, by pushing back against a system that devalues human connection, whether that means changing our funding priorities or redesigning our clinical environments. We all need to make the time to connect. It's not going to be easy. I've been there, running as fast as possible from patient to patient with too little time and too little patience for my patients. One of the many patients that taught me this lesson taught me the power of listening, communication, and connection was a woman we'll call Sarah. It was a typical busy clinic day, and Sarah was coming in to see me as a new patient for evaluation of post-nasal drip. Prior to seeing her, I looked through her chart, and I learned that she had a history of addiction, and she was 10 years sober. That she had been complaining of post-nasal drip for about 4 months, and that she had already seen several doctors who presumed a diagnosis of anorexia and were recommending admission to the hospital for inpatient treatment. I entered the exam room and introduced myself to Sarah, a tall, very thin woman with a concerned yet hopeful expression on her face. I sat across from her and asked how I could help, and she immediately burst into tears. "I really hope you could help me," she said. My first thought, I don't have time for this. But her bold vulnerability compelled me to listen. She told me that she was not, in fact, anorexic. She said that the mucus draining in the back of her throat was making her nauseous and unable to eat. And that was the reason she was losing weight. I learned she had other symptoms, including nasal congestion and reduced sense of smell, and that she felt amazing and would eat normally, though only temporarily when she was on an anti-inflammatory medication called prednisone. Quickly, I began to feel confident in her diagnosis. Her physical exam findings and a CAT scan confirmed my suspicions. A sinus in the back of her head, called the sphenoid sinus, was chock full of mucus. That was the source of her symptoms. And there it was. She'd given me the diagnosis within a matter of minutes. She was dealing with chronic sphenoid sinusitis, not anorexia. The data is clear. The solution within our grasp. To clinicians, commit to the 2-minute rule. Give every patient just 2 minutes of your undivided attention and presence. To hospital administrators and policymakers, recognize that listening, communication, and genuine human connection are essential for patient safety. And to everyone, spread this message. Share these statistics, because someday you or someone you love will be a patient, and your life may depend on being heard. We have the data, we have the solutions. Now we need the will, not just to act, but to listen. Thank you.